Welcome to a brand new episode of Seize the Moment podcast. And today we have a very special guest. We have Dr. Robert Smith. He's internationally recognized for his evidence-based teaching innovations in mental health care and the doctor-patient relationship as developer of the first evidence-based, patient-centered method to guide teachers and their medical and nursing students and residents to master a physician's single most important skill, the ability to communicate and form a strong partnership with the patient. Among many awards, Dr. Smith has received the Master Recognition from the American College of Physicians, the George Engel Award for Outstanding Research from the Academy on Communication in Healthcare, and the Career Teaching Achievement Award from the Society of General Internal Medicine. In his newest book, coming out March 4th this year, it's called Has Medicine Lost Its Mind? Why Our Mental Health System is Failing Us and What Should Be Done to Cure It. Doctor, it's a pleasure to have you on, and thank you so much for being here today.
Thank you. I'm honored to be here.
Absolutely. And you are our first guest of 2025. Okay, so in his book, Robert wrote, it has long been recognized that there is an extreme shortage of mental health care professionals in the United States. This has led to the stunning fact that most treatment of mental health problems is conducted by primary care and other medical physicians who are not trained to diagnose and treat mental disorders. Yet those in charge of mental health healthcare planning continue to omit this training in the medical schools and residencies that prepare for physicians for clinical practice. The result, substandard care for most with mental illnesses like depression and more broadly, those with less severe but very common mental health issues such as stress. Medicine does not live up to the high principles it embraces: ease of access of care, quality of care, and safety of care. So let's begin with pretty much something more or less simple. So when we think of, because I want to kind of try to frame this from, let's say, the ordinary person's perspective. So when we think of mental health care, I mean, we often think that if I go to the doctor's kind of more or less going to know what's going on, right? So if let's say I have depression, anxiety, it would seem like it would make sense that the GP would be in a position to not only treat it, to understand it, assess it, diagnose it, etc., right? So how come in your conception of what's going on, this feels or seems problematic?
Yeah, you're right. What happens is most people, even if they have a psychiatric problem, don't fully recognize it, and they go to their primary care doctor first and foremost for whatever their health problem may be. And it is there that some of the problem arises. And you alluded to it in the material you were just reading. It has evolved that there is now a mental health crisis. I think everybody recognizes that anymore since COVID. And Thomas Insel, who's the former director of the National Institute of Mental Health, who, if anyone would recognize better, says that this is not only a mental health crisis, but that it is an ethical, moral crisis. It's a human rights crisis. So mental health care is bad. There is no question about it. And I've been working in this field since 1978 or so, as have many other people. And we have been trying to get medicine to improve mental health care. And this basically means to train doctors, more and more doctors, to provide the mental health care. Medicine has refused to do this. It simply is in one ear and out the other when we show them the research-based methods they need to implement. And it's because of that I've decided to go outside medicine. We need to appeal to the public. This is something medicine is not going to do on its own, I'm afraid. And your listeners may be frightened by what I'm about to say. But simply put, given a mental health crisis of some 100 million people in the US at any one time have a mental health problem, medicine, most mental health care is being conducted by primary care doctors. Okay?
Yeah.
That's who you go to first when you have a mental health problem. Here's the problem that medicine ignores. Medicine does not train these primary care doctors to provide mental health care. And the result is completely predictable. They miss most diagnoses altogether. And when they make a diagnosis or a proper treatment, it's ineffective. This is demonstrable from multiple research projects. And the downside of this is just tremendous. all of these people, 100 million people with unrecognized depression, anxiety, substance abuse. They're not being recognized. They can no longer have sex. They can no longer go play golf. They can no longer do what they like, movies. And it gets worse. In the more severe problems, it ends up in divorce, job loss, school failure, incarceration, homelessness. All of this because of unrecognized mental health problems.
Mhm.
Now, this
So,
sounds pretty harsh about primary care doctors. I'm one of them. It's not their fault. Medicine has failed to train them for this job. And in fact, I talk to them all the time. In fact, one of them the other day told me, he said, Bob, there's no psychiatrist in my town.
Wow.
Another one said, well, we've got a few psychiatrists, but it takes 6 to 9 months to get a patient into them. And
wow.
so the point to be made here is that psychiatry provides only 12% of all mental health care in this country. Psychology provides about the same amount. That means the rest of it, 75 to 80%, is being provided by untrained people, primary care providers, and other medical physicians. So the good news is, has mental health care, has medicine lost its mind, addresses this problem.
Mhm.
We show in here what to do from a social perspective, how to inform the public, and how to proceed politically.
So I have a question. Then that sort of begs the question. If about, let's say 70, 75% of these patients are being, with mental issues are being diagnosed, let's say by their primary care provider, what do you think is happening there? Is there a lot of I imagine, I don't have the actual data, but I imagine that there are a lot of misdiagnosis.
Yeah.
There's a lot of wrong diagnosis given.
Right.
Like maybe one person, they could be told they have depression or something like that. Maybe that's not the case. Maybe they are struggling, like you said, with
Yeah.
maybe substance
Oh,
abuse.
let me just add this really quickly. So, like, if somebody has something like a bipolar disorder, it can easily be missed, especially if you're only coming to see your PCP maybe once every 6 months. Some people come in once a year. Usually, if you're on meds, you can come in at the very least once every 3 months. So, what happens is if somebody says, "Hey, I'm really depressed," they're not aware of what manic or hypomanic episodes are, they're just going to be put on an antidepressant, which is A, not going to either be effective, or B, going to actually be pretty harmful. So, yeah, that happens too. Just go ahead. Sorry.
No, and that's actually very alarming. I mean, I guess the question is also why do you think there's such resistance systemically at the moment to incorporating that into what's taught in medical schools? Because it does seem blaringly obvious that it should
Yeah.
be. Yeah.
It's just blatantly obvious. That's the title of the book. Has medicine lost its blooming mind?
Mm-hmm.
Yeah.
How could you do something this stupid?
Mm-hmm.
Yeah.
I mean, that's the title of the book. That's why there's a deeper level to that we may want to cover, but on the surface. But to your original question, when patients come in who have a mental disorder, not recognized, most doctors don't even recognize it. It's only a few people who get recognized and treated, and in those cases, the diagnosis and treatment is usually wrong.
Mm-hmm.
And again, this sounds harsh about them, but I go through and has medicine lost its mind about my own experiences with it and trying to learn it on my own, and it didn't work. I performed very poorly. I'm embarrassed to say. That's how I then got back into learning more and more about this. Um, you're asking the question, has medicine lost its mind? Well, how could it do such a silly thing as not train the people who provide the care?
Mm-hmm.
Right.
To your question now, at a deeper level, there is an explanation. Mental health care was incorporated into medicine from the time of Hippocrates in the 5th century BC up until the 16th century scientific revolution.
Mm-hmm.
Bipolar disorder and what they call melancholia were common fare, and the doctors at that point managed those just like they managed tuberculosis and all other sorts of problems.
Wow.
Come the 16th century, the scientific revolution, then this is a scientific revolution across the board. It was in physics and math and all. Medicine was just one part of this. But the Catholic Church had governed all of society, including science, from about the 2nd century AD up until the scientific revolution. There was a burgeoning at this point of scientific interest. Let's advance science. And the church resisted, but realized that they needed to make some changes. And in medicine, the basic science, not surprising, was anatomy. Anatomy of the human body. Up until that point, however, dissections of the human body had been prohibited. The church viewed them as blasphemous. And so doctors relied on dissections of goats, pigs, so on, and assumed that these findings in animals were normal in humans, which of course is incorrect. And so in 1537, Pope Clement relented and formally approved dissection of the human body for medical education and scientific purposes. But there was one proviso.
Mm-hmm.
The head, and this is a little grisly, had to be decapitated from the body before the dissection took place and turned over to church authorities, who then buried it. So that anatomy began from the neck down. The church viewed the head, the mind, as the soul and the spirit. This is how that got. So medicine, in a sense, literally was decapitated and figuratively decapitated. And that meant that scientific medicine, from beginning with anatomy, focused just on the physical body. And so dramatic changes occurred following that. I mean, Andreas Vesalius was the anatomist that did all the earth-shattering work. They found new findings after another, and he established modern scientific method. And so that was the beginning of it, but it even got further cemented. This is called the mind-body split, if I didn't say that. In other words, the mind was split off from the physical body. Okay, come the next century, 17th century, René Descartes and others, John Locke, Thomas Hobbes, provided the philosophical basis for the mind-body split. Descartes' famous, I think, therefore I am, put issues of the mind just occurring spontaneously, weren't observable from the outside. They occurred and entirely independent of physical things that you could view from the outside. And so that split was furthered there. Now, many people view this as a compromise with the Catholic Church. The church gets the mind, body, and the spirit. Medicine as a science gets the rest of it. And in long and short, that's the origin of this. It then, that's clear back now in the 16th and 17th centuries. It was not until the middle of the 1800s or the 1700s that it began to be translated clinically. And it was not until the 1900s, early 1900s, late 1800s, that there was any benefit from it clinically. And what happened then, as you know, all these massive discoveries we've experienced in the last century. I mean, it began with the discovery of sulfa drugs, penicillin, but other drugs followed, ether, chloroform, allowed surgery that hadn't been previously possible. And that was just the beginning. all came polio vaccines, and diphtheria was controlled, and all of the acute medical and surgical disease were controlled. The long and short of it is that by the end of the century, life survival had doubled from 40 years to 80 years.
Hmm.
That is the benefit of the mind-body split. And make no bones about it, it was highly effective. So I'll stop there and let
Yeah, and then and now I'm thinking of Kreplin, and then essentially there was this overcorrection at some point where the sort of mental health doctors, the psychiatrists of the time, they essentially took back the brain and they said, okay, well, we're going to make this a part of the physical realm too. So can you talk about that? How did that happen? How do we turn mental illness from a spiritual ailment to a brain disease?
Yeah, yeah. No, that's what happened. And psychiatry psychiatry took charge of mental illness in the 1800s. Up until that point, the church had done it, and there were various just god-awful asylums where people were abused, they were beaten and murdered and whatever, just awful things. The medical people at that time, a few of them, got involved, and there was this idea you're talking about. There must be a disease causing this mental illness, causing the depression, causing the bipolar disorder. And so, kind of imbued with this idea of finding a disease cause now for psychiatric disorders, a few doctors took over these mental asylums with very, very good intent to correcting all the evils that had previously gone. Mm-hmm. And there was some precedent for this, in fact. Neurosyphilis, which is a severe brain disease, and led them to think, well, maybe there are other diseases of the brain that cause this.
Right.
The problem is that this has been then imbued in psychiatry's mindset since that time. Hmm. And for Kreplin, Freud came at the turn of the century. There was some sense at that time of psychiatry identifying its more humane, emotionally based, person-based roots. But as psychiatry evolved into the last century, mid part of the century, particularly with the discovery of thorazine for schizophrenia and of lithium for bipolar disorder, it shifted more back to this disease orientation, that there must be a disease causing depression, bipolar, schizophrenia, and so on. Sadly, and Kenneth Kendler recently, and JAMA Psychiatry, Ann Harrington, Thomas Insel, all sorts of people. Randy Nesse is another key one, have indicated the fallacy of psychiatry proceeding on the assumption there's a brain disease causing psychiatric disorders. It simply is not happening. The idea instead is rather that the brain is probably an information processing organ, and it's unlikely to find diseases actually causing psychiatric disease. And it points to the fallacy in medical education, which goes back to the mind-body split, which is to focus just on disease. Well, when you focus just on physical disease, you don't pay attention to the person. You don't pay attention to their environment or their social life.
Right.
And so that's the fallacy, is that not only is all of medicine, but so also is psychiatry, anchored in this old mind-body split. It's called the biomedical model today. And we can talk, if you want, about more what ought to replace that, because it does exist, although medicine ignores it.
Mm-hmm. No, for sure. I mean, yeah, please, if you'd like, yeah, we could discuss the biopsychosocial.
Wait, can we, just before we get in, did you want to say something else, or because Go ahead.
Yeah, one thing that's I guess one thing that's on my mind is if all of these PCPs are essentially, sorry, primary care doctors
Hmm.
are essentially misdiagnosing all these people, kind of overvaluing what's happening physically with that particular patient,
Yeah.
not taking into regard, maybe they just went through a divorce, maybe they're just incredibly depressed, and that's what's physically like having the biggest cause, at least for what's ailing them physically. It's actually it's very concerning because if this is not something that's taught for doctors to address or to identify, then I mean it causes huge problems. I have a
No,
friend who I have a friend who was depressed and he was actually offered Xanax and he just abuses it essentially. He just that I mean,
yeah.
sorry, he doesn't. I don't currently associate with this person, but he abused it, and uh,
Yeah.
yeah, wasn't the right way to treat him.
A couple of things that Xanax should never be used like that. But
Yeah.
um, a couple of things. Let's nail down what medical education does. It's easy to say they're not training them, but just to give you the picture of how bad this is. First off, though, understand mental health disorders are more common than heart disease and cancer combined. They're the commonest health problem there is.
Mm.
1/4 of us, on average, one out of every family of four, will have a major mental disorder sometime in the next 12 months.
Mm.
1/2 of us will have one over our lifetime. Okay, incredibly common. Medicine, charged with caring for the needs of its public who support medicine, is providing no more than 2% of total training time across medical school and residency. That's some 8 to 12 years.
Wow.
No more than 2%. The only supervised training provided during that time is for 5.2 weeks in the third year of medical school, where they take a rotation on psychiatry.
Wow.
Other than that, there is no supervised training. Now, when you talk to deans and program directors about the need to address suicide or opioid misuse, they'll say, "Oh, we do that." But if you pin them down, it's just a lecture once in a while, every once in a while.
Wow.
There
Sure.
is no
Sure.
supervised care. Now, for physical diseases, doctors spend the entire time of this 7 or 8, 10 years training with being supervised in managing physical diseases like heart attacks, strokes, cancer, and the like.
Hmm.
There is next to no supervised training in mental health for the most common health condition practitioners will see when they go into practice, just like your friend
Wow.
experienced. And that's the result. It's not their fault, though. It's not the doc's fault.
Yeah.
They're actually doing the best they can do. And I was one of them myself. And believe me, it's heartrending for the doctor to be caught in this spot.
And actually, yeah, that's something I wanted to get to. So, yeah, you talk about that in your own experience. Uh, some situations happen that kind of cause you to kind of wrestle with this idea of how
Yeah.
yeah, I was curious what kind of led to you thinking this way, kind of taking you down this path.
To changing it, you mean into mental health interests? Yeah,
Yeah, correct. Like what happened in your own experience as a doctor that kind of
yeah,
made you see, okay, this is an issue that needs to be
yeah,
taken care of. Yeah.
yeah. It came gradual, and it came more of my own emotional discomfort with it. There was a patient I saw in residency, um, who came in with bad blood pressure troubles and so on, and it couldn't be controlled, and he eventually died of it. The long and short of it, nobody paid any attention to his emotional needs during this. He lay curled up in the side of his bed, hardly talking after he'd been there for a month or so. nobody, and we would wonder and look, and you could tell by the look on the faces of the faculty themselves, they were worried, but they didn't know what to do. People simply didn't know to ask about depression or his personal life.
Hmm.
And it bothered me. And one of this is in the book, but it after he died, he had, I still remember it. There was a tube of toothpaste at his bedside. It's called Vadimecum.
Mm-hmm.
And I always knew that. It just stood out somehow in my mind. And after he died, I stumbled onto the meaning of this in a dictionary, and it's go with me.
Hmm.
Nobody went with him. He died isolated, painful death,
Mm-hmm.
not only for the physical disease he had, but for the lack of. And the same obtains today. Terminal cancer people, terminal COPD people, terminal whatever, people with advanced physical illnesses. Doctors don't address the psychological and social aspects of that. They don't know to do it, and much less how to do it. It is not easy to do, and it takes supervised training, and they do not receive that at all. And I mean, I can go on and on. I'm not sure how much. There was another patient I saw. This is after I'd gone into practice, and what really precipitated this, my still gradual transition. But long story short, she came in with advanced breast cancer in her spine and would ask, "What do I do? What's next? How can you help me?" And I didn't, I just froze. I had no idea how to handle something like that. And so I'd order a test, and I knew it wasn't going to do any good, but it bought time and so on. And after she died, and I was very relieved when she died, and I actually liked her too. She was a nice woman. And so there was just that tension with that all the time. But I was glad she died because she no longer would come in and make me feel bad, much less me making her feel bad.
Sure, sure.
Her husband came in and said, "I thought you might be interested in this diary she kept."
Yeah.
And he beat his way out of there immediately, just dropped it in my desk and left. And I pretty soon saw why. It was just replete with comments. The young doctor doesn't seem to care. The young doctor doesn't know what to do with me. The young doctor just orders tests. It just, and I just, I was just overwhelmed by it. I could hardly function the rest of the day or the next few days. And it really is what precipitated all of this, and long and short. And I've been in brief, went back and trained at the University of Rochester. I'm not a psychiatrist, but I took what's called biopsychosocial training, where you learn communication, doctor-patient interactions. And I also did some psychiatry, psychotherapy, and worked on inpatient psychiatry. And so what I realized in practice, even as well-intentioned as I became, is I didn't know enough mental health to help people. I wasn't sure about diagnoses, much less about treatment. And that's then why I went back and did that. And that's why I also am quite empathic about primary care docs. This is not the kind of thing you learn on a weekend lecture.
Right.
There, in fact, have been studies about training primary care doctors. They trained them for a year in one study, just in the management of depression. These are docs in practice. There was no effect. It had no impact. It takes supervised training repeatedly, over and over with suicidal patients, chronic pain patients, depressed patients, and so on. And this simply isn't happening.
Wow. Yeah.
So that's a long. I then got interested in communication. We wrote a textbook on that, and then got interested in mental health. If you communicate well with someone in what we call a patient-centered way, you're going to hear what is very personal to them. Well, I told you already that a fourth of the people in this country at any one time will have a mental disorder. You're often going to hear about their mental disorder. And yet, primary care doctors don't know what to do with that. And so it struck me that I then needed to work on how to teach primary care doctors how to handle mental health care problems. And we then wrote another textbook on that. And these were all well received and were the first evidence-based studies. What we did is develop the methods for interviewing and the methods for mental health care, and then studied them in randomized controlled trials. So they're the only evidence-based methods for doing that on both counts. And so it's been a long haul from whatever it was, 1978 up till now.
Yeah. And the method used now, it's called NURS, right? Like NURS, if
Yeah,
I'm not mistaken.
yeah.
And what does that stand for, NURS?
Oh,
yeah.
And the NURS is it's a fundamental interpersonal skill. This has nothing to do with medicine. We derived that term to help doctors remember what to do. You interview someone, and eventually, if you're doing it right, you will come to their emotion. I'm sad, I'm happy, I'm angry, I'm depressed. Once you have understood the emotion, you nurse it. And indeed, try this with your spouse, with your friends, with somebody you stand in line with at the bank. Ask them how they're doing. They'll tell you, oh, it's awful, I feel awful. Or your spouse, and he says, awful day. How's that make you feel? Angry. Okay. How do you respond now when you've got the emotion? You nurse it. And I'll give you an example here. You name it, understand it. This is NURS. Name, understand, respect, support. Made you angry, naming. I can understand that. Understanding. You've been through a lot with that. Let's you and I work on that together. Those are the 4 NURS skills. And you don't use them all 4 at a time like that. And you sprinkle them, though, multiple times over an interview. And one time you may say, oh, that really pissed you off, didn't it? 30 seconds later, I get it. I understand that. 30 seconds later, let's work on that. I think you and I got something to work on together here. And these are, it is the use of these skills. These, in fact, people always tell you to be empathic, don't they? These are the empathic skills. This is how one is empathic. NURS, name, understand, respect, support. Multiply used. And that is the key to establishing in medicine doctor-patient relationship. But in real life, establishing a boss-worker relationship, a spouse relationship, a father-son relationship, whatever it might be. All relationships are mediated by emotions, but the emotions must be acknowledged empathically with NURS.
Yeah, and you know what's so interesting is, so we think about and talk about how only about 12% of the mental health care is attributed to psychiatry. So, but me as a psychotherapist, what happens is I tend to refer people out to psychiatrists and psychiatric nurse practitioners. And what's so interesting is at this point, I've only gone to about 2 people that I actually can refer people to. So what happened was I referred people to people that I didn't necessarily know. They had people that they went to on their own. So it's so interesting how kind of across the board, how psychiatry tends to be pretty bad. So I just try my best not to be biased here, because I really do appreciate. So I want to give a shout out to Jenny at Ready Well Psychiatry, because she's one of the people. She'll probably be happy that I did this, because she's one of the people that I refer people to. But so the thing is with the psychiatrists that I tend to refer people to, so they spend a pretty inordinate amount of time with their patients, right? And it's sad that I say the word inordinate, because what happens from the patients that I've heard from is essentially they'd come in, they'd spend about 5 to 10 minutes with the psychiatrist, and so essentially this is the information or the data that they would give them. And usually this is, we're talking on average. We're not, obviously, there are definitely outliers, but they would say something like, oh, hey, it just sounds like you have a deficit in serotonin, right? Or it sounds like you have a deficit in dopamine. Yeah, if you're depressed, it's a brain chemistry issue, right? And now you have people like Joanna Moncrief, and she pretty much labels all of psychiatry this way, which I certainly don't agree with. And she says, well, psychiatrists subscribe to the chemical imbalance theory, and the reason why it's such a failure at this point, and to some extent, I mean, she's right, but the reason why it's such a failure at this point is because this is a long ago abandoned theory, not necessarily true. But the point is to say that when you kind of see psychiatry in action, and I really don't like this anti-psychiatry movement because I've seen psychiatry at its best, and it's certainly not that. But then when you hear about the things that they say, I'm like, yeah, from my personal experiences with patients, they have told me that psychiatrists have essentially said, hey, you have this chemical imbalance, take this medication, it's going to help. Oftentimes they don't refer them to psychotherapy for whatever reason. They don't seem to think that it's necessary. And then the worst thing about it is that they don't even do adequate assessments. So I've known people who I've diagnosed with some version of bipolar disorder, and either, number one, the psychiatrist was like, oh, I just don't think you have it, which is, like, to me, meaningless, because why don't you just do a fucking assessment? If you don't think they have it, at least double check, right? Or on the other hand, if they don't think that they have it, show me how. Tell them why you disagree with the diagnosis. And psychiatrists don't want to do that. They oftentimes don't want to don't want to collaborate with the people who are other providers in other areas, which I really, really don't respect. So, but with that being said, rant over. Now I want to get into the biopsychosocial model, right? So now, if we're getting away from the brain model of mental illness, and we're getting away from, let's say, whatever the church's spiritual conception of it is, because at this point it's not really important to get into. But so what is the biopsychosocial model, and how does that help us in all facets, whether we're talking about psychiatry, psychology, peer support, right? When we're talking about all of these different facets of mental health.
Sure. No, good question, and a big one. Let me preface it and say that all sciences began back in the scientific revolution in a so-called reductionistic way, just like medicine is, focusing on just the physical and excluding the psychological and social. Yeah. They were all reductionistic, focusing on just part of their discipline. Mm-hmm. As it evolved, however, all sciences other than medicine have evolved into what's called a systems view of life. And a systems view, in very rough outline, means that the scientist, whatever his science, she concerns all parts of the science, not just one or two parts. One or two parts don't understand it. You have to understand all parts, and more importantly, their interaction with each other.
Of course.
That's what medicine has failed to do. It simply focuses on the physical part and excludes the psychological and the broader social dimension of human beings. All other sciences have made this leap. You will be familiar with physics, for example. At the turn of the century, Einstein general and special relativity theories, quantum theories from Planck, and so on, all of that stuff came through a broader systems perspective of science, ecology, modern biology. All the sciences have done this, except medicine. And some of these are over 100 years ago that these sciences have advanced. Mm-hmm. And so we're looking at a conceptual arrest in medicine, notwithstanding that it did wonderful work doubling life survival with the reductionistic approach. But it's just like physics. Newtonian physics was reductionistic. Mm-hmm. And it was wonderfully effective. But relativity theory and quantum theory replaced it, but built upon it. They didn't get rid of it.
Right.
We still use Newtonian physics, probably more than the others. Mm-hmm. But so we have built upon them. It's the same in medicine. Nobody is talking about scrapping the wonderful things medicine does from the neck down. We got to keep those, the doubled life survival. Mm-hmm. But it's a conceptual arrest of medicine not to adopt the systems approach that brings in the mind and the broader environment. And so that in a nutshell is what is the backdrop of it. The biopsychosocial model then is derived from a systems approach to medicine. It values the biological part, that's the part below the neck, from the neck down, rather, the physical part, the physical disease, but it also incorporates the psychological part and the social part. So it's biopsychosocial, and it spans across the systems hierarchy of things. It starts clear down with, quarks and antiquarks and so on, and you work your way up through, molecules and into physical systems with organs and so on, and clear up then into the cosmos, just in a progressive way. And medicine encompasses that part from probably from chemistry, although you're not even getting down to the genetics of it, but up to the sociological and anthropological part. But it's biopsychosocial. And it's absolutely essential. And without doing this, medicine will never advance. Medicine today, as you know, we spend twice as much and are getting worse care than 17 or 18 other Western countries. And so this is part of the problem. Is medicine has not adopted a biopsychosocial approach, and it must do that. Now, it for a long time was said by the reductionistic physical disease people, biopsychosocial model is not scientific, they said. Well, what we did, and this is some of the work we did at Michigan State, we identified, in other words, the question was, okay, you want all biopsychosocial information about somebody? It'd take 10 years to get all that. So we identified the so-called patient-centered method by which you obtain relevant biopsychosocial information from the patient. And we studied this then in several randomized controlled trials, and it's now an evidence-based patient-centered interviewing method. And it is effective. It not only can be taught easily, but it is associated when a doctor uses it, it is associated with improved health outcomes in their patients. And so that it is well established now what medicine needs to do. And we've also developed this other primary care mental health care model. In fact, it's in these two textbooks back here. There they are. It's evidence-based, and it tells medicine what it needs to do. And I'm certainly not the only one that's worked on this. Thousands of other people have worked and provided the basis for the work we've done in both of those evidence-based models. Standing on the shoulders of giants, as it were, is what we did. And so medicine now has what to do to make the biopsychosocial model scientific. It still doesn't do it. And we're getting to the point, Hannah Arendt, who is a historian and philosopher, brilliant one in my mind, warned people that sciences should not be allowed to govern themselves and determine their direction without public input. Medicine is a case in point. It has gone off the rails, and it shows no evidence of being able to right itself. And so this is exactly what she's talking about. Medicine has been off the rails now probably for the last 50 years. And certainly medicine is still doing great with physical diseases. But even in physical diseases, that's medicine's forte. Even in physical diseases, medicine is performing inadequately.
Mm.
And here's how. All of their successes worked with acute disorders and acute surgical problems. These people either died or they made it, in which
Right.
case mental illness and so on, psychosocial didn't make any difference. They went away and only came back when they had another acute illness.
Sure.
Chronic illnesses and mental disorders have become the most common health problems in the US. I've already mentioned mental health, but chronic physical illnesses, diabetes, heart disease, heart failure, cancer, strokes, emphysema, there's a whole list of them. These are now the most common disorders. It's easy to see how the mind-body split, avoiding psychological and social, makes mental health problems off the radar screen of medicine.
Mm-hmm.
But how do they make chronic diseases worse in medicine by excluding psychological and social? Okay, here's how. Almost all chronic diseases are caused by lifestyle factors,
Mm-hmm.
all of which are psychological and social. Drinking too much, eating too much, smoking too much, not exercising, stress, and so on and so on. These are all psychological and social factors. The social part, access to health care, inadequate payment of physicians, and so on. All of these are largely omitted by medicine. It has been shown 17% of all people with chronic disease, and you can understand this because when chronic disease gets bad and you can't exercise, you can't watch TV, you can't have sex, people get depressed.
Right.
Severe disease makes people depressed. Okay? 17% of chronic disease people are also depressed or anxious or addicted to, or using addictive medications. Doctors don't recognize the psychosocial aspects, the mental health aspects. The problem is you have to treat those aspects to get the physical disease well.
Mm-hmm. Yeah.
And so that's just one example. An even bigger example is this. All of these lifestyle factors that cause chronic diseases, prototype is cigarettes cause cancer, cause emphysema, cause heart disease, overeating, same types of things, cancer and whatnot. Okay. 80% of all heart disease, stroke, and diabetes can be prevented if we control these lifestyle factors. 40% of all cancers can be prevented by controlling lifestyle features. Medicine ignores this completely. Medicine, instead of preventing all this carnage to the population that supports it, waits for the disease to happen,
right,
and then spends inordinate amounts of money treating it when it could be prevented in the first place. And so it goes on and on. So the long and short here is chronic disease care is now compromised for lack of use of a biopsychosocial model. And there is no question about that. We haven't even talked about the costs that could be saved from this.
Right.
But
yeah.
We've talked about the carnage to the health of the US population. The costs are unbelievable that could be saved.
Yeah, and to add on to that, so what's so interesting is that I think a lot of people don't know this. I mean, I don't know how common it is, to be honest. But the thinking is that usually it's counterindicated to give medication, psychiatric medication, for people struggling with either mild anxiety or mild depression. Usually you would just refer them out to psychology or psychotherapy just broadly. So, but what's so interesting is that because that's the case, I think, unfortunately, or it should be the case, unfortunately, what happens is people either go to psychology, like we're talking about these silos, right? So people either either go to psychotherapy, and a lot of times, so what happens is they're not really able to withstand treatment. It's very difficult, obviously, depending on the nature of the illness. Or on top of that, or rather, instead of that, they go to psychiatry and they just get medicated, and it's sort of in perpetuity, right? So the thing is, what I want to say is, and why biopsychosocial here is super important, is the bio part is supposed to be the psychiatry, but then the psychosocial part is the psychology. This is where you go and you make lifestyle changes. Obviously, you figure out where your low self-esteem is coming from. You deal with potential traumas that may have occurred to you. But the point is to say, this is what I'm really getting at. So people tend to have this kind of sort of, what's the word, nefarious kind of perspective of psychiatry, where the thinking is, well, psychiatrists just want you to be on medication forever. And I would say, yeah, that's bad psychiatry. So good psychiatry is supposed to, again, through assessment, they're supposed to figure out, okay, does this person mildly depressed, moderately, severely, let's say in that area. And then if they're more mildly and more moderately and severely depressed, then the idea is, okay, we refer them to psychologists or a psychotherapist. We work together. We make sure, obviously, with medication management, we kind of get updates. We do constant assessing, and then we figure out like what it is about psychotherapy that is and isn't working. But the idea is with medication, you're not just supposed to take medication. Ideally, again, unless you're somebody who's severely and obviously chronically depressed, I mean, then unfortunately, for the most part, that's probably going to be a part of your life. But if that's not the case, if it's, let's say, more or less situational, right? The idea is psychotherapy is supposed to help you get out of that or get off of that. And it's supposed to help you make the changes and to have the self-esteem necessary to be able to go forth in your life and make decisions that are good for you. So again, I just want to kind of combat that, because I know some listeners will be thinking, well, psychiatry, they want to get you on pills. You guys are even to some extent saying that they kind of call it a chemical imbalance. And again, I really want to be clear on this, that is bad psychiatry. When you go see a good psychiatrist, for the most part, they're not just siloed away in their little sphere, and they're not just pumping you with medication. For the most part, they're working with a bunch of different organizations. And again, I really stress this too, even some sort of peer support like AA or anything like that, that's also helpful too. And we kind of view it again, so biopsychosocially, that all of these things matter.
Yeah, no question about it. And it's what we talked about before. Psychiatry is oriented toward physical disease, hoping to find a physical disease in the brain. And in these chemical theories going along with that is drug use to manipulate the various chemical imbalances. And these drugs are effective. That's the bio part. But it also requires psychotherapy at the psychological part and social part. And so they go together. Psychology, in my opinion, has been a tremendous addition to the medical armamentarium, if you will, even though organizationally they lie outside of medicine.
Right.
But they have been tremendously helpful. For example, many people say, well, psychologists can't prescribe medications. Well, it turns out that the psychotherapy they do is as or more effective than medications for, say, depression or anxiety. And indeed, patients often prefer that. So psychology, in my mind, has to become better woven into medicine. The American Psychological Association, and now many years ago, I can't remember exactly when, but advised postdoc training in medical settings for psychologists so they can learn to function right in medical settings and prescribe medication. Many states with some special training allow psychologists to prescribe. And I've worked with actually the very first one of these programs in Flint, Michigan, and it's very effective. But we need to get more psychologists into the medical system and comfortable working in it, because they're a tremendous asset.
Yeah, and let me just add this, and then also what's super interesting is, for the most part, so I can't really count how many times this has happened, but this is, I would say, pretty much a decent amount of times. So I would have patients tell me that, hey, before I actually started seeing a psychiatrist, like a lot of the stuff that we were talking about in therapy, it just didn't sink in. So the sort of chatter, like the inner critic, it just wouldn't allow me to believe it. And now, when we talk about these things and I'm on medication, I feel like I have the right dose, the right, let's say, brand, whatever. The point is to say that I'm now able to take it in a way that feels more logical. So whereas before, it kind of just felt like a jumble of ideas, right? So I'd hear sort sort of your framing of it. Then I hear my own framing of it. I wasn't really
Yeah.
able to make sense of it, right? So that I was always emotionally aroused, super aroused in the sessions, right? But fundamentally, what happened was after the medication kind of kicked in, whatever the span was for, kind of different for each person. But like the point is to say, once the medication was actually effective, I felt like I can actually make use of therapy. And so again, ideally, that's what we want. We want somebody, again, unless they have a milder version of, some mental health issue, what we want it for the most part, because I don't want to make it that general. But the point is to say that we want people to be sort of in every sphere possible. And again, that's why I love the biopsychosocial model so much, because it's like, there's this great line by the rapper Tupac Shakur where he says, you can't be an angel if you're living in hell, right? That's the social part. So I think the idea is it's not so much just the person or just their mental illness, it's the environment too that matters. And that's what I appreciate so much about your work. But here's then the question, right? And this is, I think, going to be probably the most difficult one and maybe the most important one as we begin to wrap up. So what do you think? Like, how should we address it, and how should we teach the biopsychosocial model when honestly a lot of people find it to be overly complicated?
Yep. People who find it overly complicated simply have not been exposed to it, and it's kind of a defensive mechanism. And people imbued with the biomedical model know nothing other than the biomedical model. They're like the fish that knows only water. That this fish has to get out of the water and see what the air is like, and which is to get out of the medical part and get into the psychological and social. It is complex to them because they're not taught it. If they were taught the biopsychosocial model half the amount of time they've been taught the biomedical model, it would be easy and reflexive. It is not simple to learn. Patient-centered skills are not simple. Primary care mental health care is not simple. It requires, again, supervised training and evidence-based methods, and repeatedly supervised. So it is complex to people that have never heard it, just like biomedicine is complex to the medical student that has never heard it until that point. And so that's the issue. That is, it must be implemented. It is the system's view of medicine. And I think you're asking also, how are we going to do this with a recalcitrant medicine?
Yeah.
Okay, what do you do? Well, that's what Has Medicine Lost Its Mind is about. You go to the public. I'm talking to your listeners. I want to activate them. I want to get them upset. I want to get them concerned why they don't know that most of their mental health care is being provided by untrained people. Why that is happening. And you get an upset populace, they will demand of their politicians that change take place. And we have examples of this already. I don't know, you guys are maybe young enough, you don't remember this, but Ralph Nader's Unsafe at Any Speed.
Yeah, I know.
The automobile industry had gear shifts that didn't work right, and they had seat belts, but they didn't change any of it. It was just simply going to cost them too much to do it. They knew seat belts worked, but they didn't want to do it. Ralph Nader's Unsafe at Any Speed came out and angered the public, so they insisted that their politicians change things. And that led to the, I've forgotten the exact title, but the Automobile Health and Traffic Safety Act. Rachel Carson came along with Silent Spring. Up until that point, the chemical industry was polluting everything they stepped on. There was even DDT in our water.
Yeah.
They knew it, but they didn't do anything about it because it would cost too much. Rachel Carson comes along, irritates the public. They get their politicians going. That's why we have the Environmental Protection Agency today. And Has Medicine Lost Its Mind can do the very same thing with medicine. An upset public will insist that its politicians do something about this. After all, medicine's task is to take care of the people. You can't omit 50% of the healthcare population and say you're doing your job. The public supports medicine. And back to Hannah Arendt, Society has to control what a science is doing. We see the same thing in gene manipulation. Society has said they don't want test tube babies, and they're not going to happen. And that's because society got involved. Society has to get involved with medicine and tell medicine what needs to be done and to start meeting its needs. And to do this, it has to grow conceptually out of the old mind-body split into the modern systems-based biopsychosocial model.
I love that. I'm curious, Robert, have you ever seen the movie Dark Waters?
Haven't,
So the reason why I mentioned that is because this echoes another podcast that we did. So, and not to get into this too much, but we had Robert Billet on, and so he was he still is an environmental lawyer. And so the movie is with Mark Ruffalo, and it's based on his character, it's based on him. And so essentially, they discovered forever chemicals, and they discovered them initially in West Virginia. We're talking like now back in what was it, the 70s or something? And then so with DuPont, they pretty much went to legal war with them. And so fundamentally, Billet was one of the sort of trailblazers of this, and now everybody talks about forever chemicals, right? You read about it everywhere. It's been on Huffington Post, whatever. But point is to say, back in his time, like people were like, what the fuck are forever chemicals? And they had to actually sue DuPont, and I think initially DuPont won a bunch of times. But so he would have argued this. He did. I mean, technically, he argued the same thing. So he took it to the public, which obviously now that it became a Hollywood movie, everybody knows about it. So that's just one great example of the change of political change we've seen.
No, and that's in medicine. Two factors are interfering with medicine. One is the mind-body split. They have to get that out of their head. Okay? I've alluded to this already, costs. There are a lot of people right now that are fat and happy with physical disease-only medicine. Hospitals, insurance companies, drug houses, equipment houses. They are making billions, if not trillions of dollars each on the situation just the way it is. And we have to decide, do we want them to keep making billions of dollars at the expense of the health of half the population? And this is what it comes down to. But that is the other impediment, is so-called medical industrial complex. And it is invested heavily in the status quo. And they will oppose any of these types of things that we're talking about right now. And so it's going to take an outraged public to insist. On my website, when I get it up, it's not there yet, there will be a spot in there with a sample letter that people can send to their senator and their congressperson, along with the addresses, the email addresses of all congressional representatives. And all they have to do is take their own email, plug the letter into it, find the address of their senator or congressperson and put it in there and send it.
Wow.
People need to be activated, and they do not know what is now going on and how badly they're being treated.
Okay. So it's I think an excellent endpoint. Okay, Alan, final questions for Robert before we wrap up.
Yes. If we wanted to follow you, follow your work, and of course, buy the book when it's out on March 4th, where can we do that?
It's available in all bookstores and, Barnes and Noble, Amazon, what have you. They're all readily available. My website, which is Robert C. Smith, MD, no spaces, robertcsmithmd.com, will have access to it there, as well as access to this place to contact your congressman.
Excellent. And also, guys, check out Robert on Psychology Today. He writes really great articles as well. Yeah. Robert, thank you so much for coming on. This was awesome. Such an excellent show.
Oh, it's my pleasure. I've enjoyed it. I'm honored to be here.
Absolutely. Take care. We'll talk to you soon.
Take care.
Okay. Bye-bye.
All right. Good show. So you can follow us at Seize the Moment Podcast on Facebook and on Instagram. On X, we're at Seize_podcast. Like, subscribe, hit the bell on YouTube. And again, thank you so much for watching, and see you next time.